and welcome to our webinar today, Improving Patient Care with Allied Health Assistance. My name is Jenny Pearson. I'm an Education Officer for the Primary Health Network. Before we go any further, I'd like to acknowledge the traditional custodians of the land that we're meeting on today and pay respect to elders past, present and emerging. Joe, I would really appreciate if you can just keep letting people in as they enter. Thank you. Part of this session will see the launch of a video highlighting allied health assistants working in different settings in the PHN region. As the health sector continues to experience workforce challenges and in the aim to work towards providing more coordinated multidisciplinary teams to provide quality person-centred continuity of care. Gosh, we look forward to showcasing today's video. The video showcases two practices, community therapy and recovery station, employing allied health assistants as part of a multidisciplinary team. The practices are also with us today. Following a short presentation on the newly established Allied Health Assistants National Association, the two practices and the association will be able to answer any questions you may have. We encourage you to ask questions. The day-to-day tasks for allied health assistants from a business perspective on employing allied health assistants and what the association can do to support your allied health assistants. We do have a question box that you can ask any questions when the time comes. You can also raise your hand there's a little icon and you can also speak. So when the time comes, we'll just cover that again. But I do think it is nice if we can all be as interactive as possible. While the video is playing and our presenters are chatting, if you can all turn your cameras off and put your microphones on silent, that would be great. Just before we go any further, our guest today, Scott Lynch, he's the founder and managing director of Community Therapy. Amy Prosser, who's the clinical lead for Recovery Station. Andrew Richardson, a director of Allied Health Assistants National Association and content coordinator for the Allied Health Academy. It's a real mouthful today. And we also have Kira Hames, who has her Certificate 4 in Allied Health Assistance and started working with Recovery Station after she completed her placement with the company in 2018. Okay, so I would just like to hand over to Amy.
Thank you so much, Jenny. Hi, I'm Amy Prosser. I'm the Clinical Ops Manager at Recovery Station, and we're a private provider here in the Hunter region and also Central Coast and Sydney. So we provide services to NDIS and ageing clients, so disability and aged care, and we're primarily working in the community with clients, aiming to help them live their best quality life by providing services over 7 different allied health disciplines. We've been extremely fortunate to build our allied health assistant team to 6 fantastic allied health assistants, both career allied health assistants, those that have their Certificate 4 in allied health assistance and have studied to become AHAs, as well as those that are completing their last 2 years in allied health specific degrees at university and are assisting us during that period while they're doing their studies. And AHA has really transformed a lot of the services that we provide to our clients in so many ways. They help us by providing a lot of the ongoing therapy for a lot of our really stable clients, where they can provide a lot more face-to-face ongoing therapeutic intervention, and then highlighting to our clinicians if there is anything that needs to be addressed with further assessment or grading and adapting of the program. They're able to see them probably twice as frequently as what the allied health professional can because of the funding scaling, and they get to do often what the clients deem as the fun stuff, the good stuff, because it's the stuff that the clients really, really want. They really, really need. It's a lot of the ongoing therapy, the really good interventions, and they are seeing so many excellent outcomes that we're getting ongoing requests for hours to be spent with the AHAs, and we're getting ongoing requests because they love our allied health assistants. We are really, really lucky. We have a beautiful team. I'm incredibly proud to have Kira here with me, who is one of our senior AHAs, who also supervises other AHAs and has been with our team since 2018 and is a very experienced and fantastic allied health assistant, who you'll get to see in the video working with some clients as well, and is very passionate about her job. So I won't really take up any more time other than I'm here to answer any questions as well, and so is Kira later on. But I would strongly encourage other people to consider allied health assistants in their business models, because your clients will benefit, your company will benefit, your clinicians will love working with allied health assistants. It means they can do that ongoing therapeutic interventions, and your clinicians can focus on doing the reports and things. And actually you'll get better turnover in terms of the number of clients that you're seeing, and your clients are getting a lot more therapeutic intervention than what you can offer them otherwise, which is so brilliant. It's a win for everyone. So now let me hand over to Scott to introduce himself and Keely as well, and tell you a bit more about themselves.
Thanks so much, Amy. Great overview. I'll try not to double up on that because I agree with all of the benefits that you've provided to everyone of allied health assistants as part of a workforce. So I might just give a quick overview of community therapy and then hand to Keely for a little bit of a perspective from allied health assistant for best usage of time. But my name's Scott Lynch. I'm a physiotherapist by background, graduating from the University of Newcastle. More years ago than I like to count now. So I founded community therapy around 2017. So we're about 6 years old, a bit over that as a company. And I sit as managing director now. There's about 130 of us across the Central Coast and Hunter New England health regions. We primarily started as supporting residential aged care facilities and still do in our partnerships there, as well as community aged care, rehabilitation at home for post-surgical programs, partnering with different private hospitals and providers. And we do a range of things in the online learning space as well, with our most popular course being our online manual handling course and series for aged care and NDIS providers. So in terms of allied health assistant as part of our workforce, we consider it essential. And I think we're seeing that from different departments as well, with different steering committees at a Department of Health and Aging level, and also with the NDIA. So, and Amy spoke really well to all of those benefits there. So we see a lot of internal benefits in team culture as well, and Keely's a really good example of that, of really driving multidisciplinary practice and linking up different clinicians that are looking after the same client or groups of clients. And Keely does an amazing job of like sharing wins across the MDT team and goals, which is really nice. So I think, some questions to consider if there's time after we all see the video is maybe sometimes practical questions around what does the implementation of an allied health assistant model of care look like if you haven't done it before. New South Wales Health has a really good delegation framework that private organisations can use as inspiration to piggyback through. And I think sometimes there's practical implications of reviewing your insurance policy as an organisation to know what is the definition of an allied health assistant. Is it your insurer only considering certain levels of certificates, or like Amy said, are they happy to cover the last couple of years of undergraduate allied health professionals, and making sure that you have that underwritten for your policy is a really important compliance level and risk management for an organisation. And then I guess practically at a clinical level, is it how do you just make that work simply? How does assessment and delegation and review happens simply from a clinician level and an allied health assistant level. So those are some practical questions that I'm sure we would all be happy to try and answer within the time, but I might hand to Keely for a little bit of an introduction of yourself and maybe, you know, some of the, you know, key benefits of what you see allied health assistant brings.
Lovely. Hello, everyone. So my name is Keely. As Scott said, I am an allied health assistant at community therapy. As far as my background, I've been very privileged to work in community development overseas for not-for-profits, and I've always sort of dabbled in working with people, trying to improve many sort of socio-cultural, educational outcomes, things like that. So then it just naturally led me into working in allied health. I've had the pleasure of working for other companies assisting occupational therapists. However, I've really come into my own here at community therapy, and I'm really enjoying working with physiotherapists and speech therapists. I find it very hands-on, and I also do really enjoy the functional, trying to get the client to reach more functional goals. Something as simple as one of my clients who's had a long history of speech therapy, now actually adjusting his speech therapy to be a simple functional goal of completing his and his wife's coffee order, which I'm proud of Punch to say he did. So yeah, as you can see, it does obviously make me quite happy, this job, and I find it very rewarding, and it's just a true privilege. One quick insight I would like to sort of give to businesses if you were to employ allied health assistant, I would say one of the strengths of community therapy in comparison to some of my other experiences would be really clear delegation, and really clearly keeping things within individual clinician scope, such as my scope, and really knowing when to be redirecting client, because as passionate as we can get, it's just the best outcome for the client, clinician, and ourselves to keep everything really clear in our scope. So yeah, it would be lovely if Scott can maybe and Amy go through that later, because I do think that makes a big difference to my enjoyment level in my job, and just reducing stress and any complications. Yeah. Thank you.
Yeah, that's well said, Keely. So we'll hand back to the team now. Thank you so much, everyone.
Great, thanks everybody. I will just share my screen and play the video.
Hi, I don't think that's working, Jenny. Rebecca, are you online? If you could. Yes, sorry, we're having some IT issues in playing the video.
I thought it was just the theatrics of suspense.
Yes. Give me a second, guys. I can share this. One moment. Just get that loaded up. Everybody see that? Yep. Apologies,
Unfortunately, it's gone again.
Can everybody see that one?
No, sorry.
You can't see.
No.
Apologies, won't be a moment. Hey, has that come up now?
Yep.
Okay, let's see. Amy, give me a thumbs up if you get the sound there.
An allied health assistant is somebody that's went through a certificate 3 or 4, typically through TAFE, and they've worked with allied health professionals to learn a range of different skills and interventions that they can do. Typically, they're supporting people with therapy, so they're helping them improve their skills and capabilities in their everyday lives to meet their goals.
Allied health assistants are there to help us provide ongoing services to clients that have been assessed by our allied health clinicians. So they're there to actually provide the ongoing treatment programs for clients that have been deemed as being stable and requiring repeat practice of specific programs.
Being an allied health assistant is such a diverse role. No 2 days are the same, and it's a lot of fun. We are implementing all these therapy programs and across disciplines such as physio, exercise physiology, speech therapy, OT, dietetics, and mental health OT. So we're across so many disciplines and each day is different.
The good thing is, if you're working as an AHA, you're always going to have new sort of disciplines emerging, and you get the opportunity to learn from every single provider. And yeah, I find it really rewarding. You're never bored and you can never get too complacent. You never think you know everything. There's always still so much more to learn.
Having skills and knowledge across all disciplines, it allows me to view the client holistically.
There's a range of benefits of having allied health assistants as part of an organisation, but I guess for us at Community Therapy and every healthcare organisation, we're here to serve the community, and allied health assistants being part of a model of care let us do that even better. It allows us to see people in a more timely manner, allows us to see people more frequently. Sometimes a physiotherapist mightn't be able to see someone enough times a week or a month that maybe an allied health assistant can help us do. So in the end, an allied health assistant's able to help support the community more when that's part of a model of care.
The allied health assistant rate is a lower rate than the allied health professional rate when we're looking at things like NDIS clients. We can actually stretch that client's funding so much further by using the allied health assistant than what we can if we're using the allied health professional. If the allied health assistant can take care of those stable clients, it means that the allied health professional is then freed up to take on more clients that are needing that assessment, report, prescription, those things. So for us, it's a win-win-win. The client wins, the clinicians win, the business wins. I would definitely encourage other organisations to use allied health assistants. It's fantastic. It's made such a difference for what we can offer.
Having an allied health assistant has been a real blessing for Wayne and I, because sometimes you don't always get the funding that you need, and now it has doubled our hours, which has been terrific, and Wayne can have more therapy, which is helping in his recovery, which has been fantastic.
I really, really love when I get to have that breakthrough moment with a client who is a bit resistant to exercise, particularly for those who have things like dementia, and they have they're quite fearful of new things, or they can be quite socially isolated. And it's just so lovely taking them out for walks in the sun and just sitting down in the courtyard and just seeing them smile, like such a simple thing. Of course, I'm very interested in all of the physio components of it, but really that's what it all boils down to, those little moments.
I love this job because I just have an absolute passion for disability, and I love building these relationships with clients and seeing them reach their goals. To go into a client's house or into an aged care facility or have them come here to the clinic to see me, to put a smile on their face and to get them excited about their therapy and just to make a difference in their lives, it means the world to me.
That's such a good video. Andy, I think we're going to hand over to you.
Yeah, lovely. Just let me share this screen. Okay, and everyone can see that?
Yes, we can.
Yes, wonderful. Just because I'm based a little bit further away from you guys down here in the ACT, I'd just like to do my own acknowledgement of country. I pay my respects to elders past, present and emerging, and extend those respects to any First Nations or Torres Strait Islander people with us here today. So thank you very much for inviting me along today. My name's Andy and I'm one of the current directors of AHANA, so the newly found governing body for allied health assistance in Australia. I'm just here to currently give updates of what we've been doing since our establishment. So basically we've been established as a national association since April last year. And some of our key milestones so far is our new website was launched on the 1st of January this year. We've been open for membership since the 1st of May. And in September, we had the privilege of attending the National Allied Health Conference in Perth, which we used as an event for our official launch. And we were officially launched as an association by Anne-Marie Boxall, the Commonwealth Chief Allied Health Officer. Okay, so we'll just cover through some of the updates of what we've done so far. So since our establishment, we've been working to try and help create clearer pathways for AHAs for workforce retention, ensuring that AHAs provide ethical services through adherence to a code of conduct, ensure minimum safety standards, and continue to maintain and develop their skills and training through a CPD program and recency of practice requirement. We've implemented an arrangement with a third party, the Allied Health Academy, to provide some other opportunities for CPD for AHAs to assist to fill gaps in accessible training so that members can meet those CPD requirements. And I'm affiliated with that platform as well, and I'm happy to answer any questions you have regarding that. We recognised a lack of data about the recognition of AHAs as a workforce, and we've engaged conversations with the ABS around the recognition of AHAs with our own singular ENSCO code. We've undertaken consultation with industry in first steps of looking at co-regulation with allied health assistance, and we're currently in negotiations with government. And the possible benefits of looking down the line of co-regulation would be to reduce the burden on overloaded allied health professionals and maximise the time they have available to service more complex and high-risk clients, help ease the financial pressures on the health system with appropriate funding for lower risk rather than a one-size-fits-all funding line, which does not cover the cost of an allied health professional that's currently required to deliver, and incentivise AHAs to become certified by AHANA. Higher levels of certification will lift the standards of the workforce as a whole through the standards that we're trying to put in place from the workforce's reputation. So for this platform, I just wanted to cover two basic alterations of the membership that we currently have on offer. So we have 3 different types of practicing membership classes. These are memberships that we'd highly recommend for AHAs that are currently working with clients. You can see the benefits available on the screen. We'd also like to mention that for these practicing membership classes, there's also an option to opt in or opt out of private indemnity insurance, if that is so required, depending on their employment status with the organisation. One of our non-practicing memberships is also an associate member. So if yourself as the owner of a business would like to keep up to date with what current CPD and other activities are available for your allied health assistants, this is a good option of membership for you, because you'd still get access to our CPD forum, the Allied Health Academy, and you can see if there's any gaps that you need to fill in regards to any of the professional development requirements based on where your AHAs are currently working. But the main difference being that this association type does not offer indemnity insurance. Okay, that's all I have to discuss with you so far regarding Ahana. Happy to answer any questions you guys might have. Thank you very much.
If you do have any questions, please feel free to type them in the chat box, or if you would like to raise your hand, I will say your name and you can put your camera on and just ask your question. So send them in now. Hi, Martina. What would you like to ask?
Yes, hi. Thank you very much. Has been a really good session so far. My name is Martina and I'm working for Primary Health Tasmania. So I'm not in your region, but like on the little island south of you. So one of the questions I had was, does any of you have like a framework that you share with your allied health professionals and their businesses that would help them basically to employ an allied health assistant, but is still a little bit unsure about how to go about it, to make it right, because there's a lot that you probably need to put in place before you get to the point of like employing someone. I would like to know whether any of you have that in place already, or if you're working on that.
You want to lead, Amy, or me?
You can go first if you like, Scott. Go for it.
Yeah, I would say that we didn't, I guess, retrospectively document the process that we did for our implementation, but the initial scoping was, as you would do with any project or new team, is what sort of risks were there. So the primary one was around insurance. So that was with myself going through to our insurer to clarify, and with our policy, we did sort of have to go back and forth on a definition, primarily to make sure undergraduate allied health professionals employed as an allied health assistant were clearly underwritten in our policy, because our policy covers everyone and we don't need then individuals to have their own insurance. So I think that was an important piece. We then did review New South Wales Health's publicly available allied health assistant framework to, I guess, get that inspiration and that building block of then, okay, what would that look like for us and what sort of things would we need in place? Now that sits more at an operations level, that document, but it allowed us to then be like, okay, what is needed out of a delegation report from a clinician to then, and what is needed out of a progress note ongoing for our allied health assistants, and then what's that sort of communication process back and forth. So yeah.
We were very much the same. We also had to look at, so one of the other documents that we considered in setup was Victorian Health actually has an excellent allied health assistant delegation framework and an allied health assistant model, which we used as well. one of the things that I think is really important is maintaining really clear clinical governance, which is that the ownership of the client specifically still remains with the allied health professional. So all clinical decision making, anything regarding things like assessment, report writing, program planning, all of those sorts of things still needs to remain, same with grading and adapting, all of that still needs to remain with the clinician. So the clinician still actually retains the clinical decision making and responsibility for the health of that client. It's delegated responsibility to a particular level with an allied health assistant, and that needs to be very clearly written into any policy and procedure. It also means that nothing can actually be delegated to the allied health assistant unless it's very clearly done in writing. And for us, our policy is that there needs to be a handover session done between the two allied health professionals, being the allied health assistant and the allied health professional. And that has to be done with the clear knowledge of the client and with very set guidelines of what the scope and boundaries are for the allied health assistant, because it's protecting everyone in that situation. It's protecting the client, but as Keely pointed out, it's vitally important that the AHA is protected in that situation as well. If the client is expecting the AHA to act as an allied health professional and be prescribing them things or completing assessments or providing them with diagnostic tools and things like that, that's not fair to be placing that on the allied health assistant either. And that's when they need to be actually going back to the allied health professional. So we also have very clear checkpoints that are established that says at every 3 months there must be a secondary visit completed where they have to actually communicate back. The AHA communicates back with the allied health professional, or there's a visit back with the allied health professional and the AHA. If they're a very stable client and there's been no changes, it might be a conversation between the AHA and the allied health professional, and then it's set for 6 months, that kind of thing. So it's all about having really clear, defined guidelines, boundaries, scope. All of that has to be set before you actually start taking on clients. And with regards to also, you need to clearly identify that with the client as well. And that needs to be identified in service agreements, all of those sorts of things too. Sorry.
So that's all right. And I'll just add to that from an additional reference point, because every state public health organisation has their own adaptation of an AHA scope of practice and delegation and supervision framework. So that would be a good first port of call just to get the appropriate structure for the delegation standpoint. Another good reference for you though would be SARA. So the Rural and Remote Health have recently created what they've referred to as an AHA toolkit. It's basically an instructional book that will go through the steps of how you'd be required to adapt your practice, based primarily more so rural and private practice, but how to adapt your practice in order to be able to add an AHA to your workforce. So that might be a good point of reference as well.
Yeah. The final step in it, I think, is also going back to your existing clinicians and educating them around the role of the AHA, because it's great to bring somebody into your workforce, but unless those that are already working within the workforce are aware of how to refer, when to refer, and all of those sorts of things, you can set up the best resource and bring in the best person and have somebody fantastic, and it may still not work because you actually need to make sure that they're welcomed and they are shown the respect that they need as well within their organisation, and they're not pushed outside of their scope. They're not disrespected by not having the things set up that they require to do their job as well. So it is really important that it works both ways, and that the clinicians that they're brought in to work with, if it's a new service being provided, are really aware of what an AHA does, how to work with an AHA, how to make appropriate referrals, what are appropriate referrals, and all of those sorts of things.
a really good point. It was probably the primary barrier once we sorted operations and risk out, that it's just like anything starting the first part of a service, and there are some unique barriers there of getting clinicians that may have, at the beginning, the most suitable clients may have been people with quite long-standing therapy with that clinician and a very strong rapport and relationship. So being able to have that handover process takes some care, and so some training and some scripts around how to maintain those professional boundaries and rapport was important. The other barrier we faced, in particular in the community aged care setting, was our partner organisations just not really having an understanding of the allied health assistant model of care and value. We certainly faced that in the NDIS sector, but not as much. There was more of an initial appetite for that model of care and an appreciation of the values that it brings, but aged care was very difficult. So we did a lot of brochures and conversations and just reaching out to, before we even started, just to try and make it a little bit easier for our clinicians to have those conversations and get that approval for that to occur. So scoping that out is important before even starting.
Yeah.
We have had some questions coming through the chat box, which is fantastic. Joe Coots has been onto them. Would anybody else like to ask a question? Alicia Pratt's just actually sent through a question which I might read out. Did you employ people with existing AHA qualifications, or were they trainees?
I can speak to that initially. Yeah. We had a combination. We've had a combination of either pre-existing, completing studies, or undergraduate. So.
Yeah, we're the same. So Kira was our original AHA, and she did placement with us and for her Cert 4, but already had her disability certificate, and then became our first AHA, which was amazing. And since then, we're now up to 6 AHAs, and we have a combination of both what I mean, it's not probably the correct terminology, but what I call career allied health assistants. So people who have come to us because they've chosen to study to be an allied health assistant and have done their certificate, versus those who have chosen to be an allied health assistant while they are completing their undergraduate studies. So for us, it's usually a combination of the two.
Andy, did you want to comment on anything else?
No, it was pretty much defined to the agree, because I'm one of those career AHAs. I've been working with public health for 9.5 years now, and it's fun trying to find that equal gap between the allied health professionals, because all the research seems to state that allied health professional students that start with employment as an AHA develop more clinical skills and clinical experience that becomes more beneficial when they're doing their placements. But the most impressive thing with the research is the research actually states that when they graduate and they become allied health professionals, they have a much better understanding of what the scope of an AHA is, and they can more appropriately delegate to the AHAs. That means that the AHAs have more consistent job satisfaction because they're working more to the top end of their scope. And then it frees up the health professionals to be able to do more of those complex tasks that they're required to do.
Really good points. Yep.
I might comment on 2 questions in the chat that are probably of value to everyone, which is one from Damien early up around award for employment paying conditions. Naturally, that's going to vary. Like that could be a disability organisation under SHADS, it could be public, it could be private, so it'll fall under your current award for your organisation. But of course, get HR advice. I'm not a HR professional. And Reese, okay, sorry, Linda, recently I attended a private practice webinar that mentioned some push to get dollars for AHA increased in the NDIS schedule, thoughts particularly with video mentioning ability to double access to supports compared to, so that have more hours fundamentally because of the discrepancy in price. My comment on that would be similar to other services, including the allied health professional line items. Typically, the hourly rate of the NDIS is lower than the private market. So whether we see that in private practice, but also in the community setting, typically the NDIS rate hasn't moved for many years now and has now remained lower than what people charge at a private level or for some other compensable schemes. My personal comments on the AHA rate for the NDIS is it's too low, and it does not value the allied health assistants' work and benefit to the model of care, so it should be reviewed.
I would echo all of that, Scott, and say the NDIS rate doesn't actually reflect the input of allied health professionals or allied health assistants. And that's probably an argument or a comment for a much, much bigger, much broader scale and a much longer episode than we have today. But yes, I think the big thing that we see there and the reason why people are pushing in that direction currently is that we're also noticing that there is a massive squeeze on the number of funded hours for any therapy everyone is getting, particularly with plan rollovers and the reduced capacity to get plan reviews and all of those sorts of things. So it's very much how do we take the small amount that we get for therapy for any client and maximise it to the absolute best that we can. And often that is by trying to look at doing things like reducing travel, using telepractice, finding those clients that are stable and who don't require things like assessments, reports, prescription, those sorts of things, and utilising our allied health assistants to be able to provide the ongoing therapy for those clients. So wherever we possibly can, we're trying to stretch every single moment that we can out of those plans as they're not getting enough hours funded in any of the plans.
Thanks, Amy and Scott. Susan, you had your hand up.
Hi guys. Hi Scott. Hi Amy.
Hi.
Sorry, I couldn't use my chat box for some reason, so I had to put my hand up. So as a podiatrist, I'm really interested in how we can use allied health assistants in our scope of practice. You guys, I don't think have any podiatrists in your team.
No.
So would you be aware of anybody that does that we could talk to about how they, Andy?
Yeah.
Yeah, so currently down here in the ACT with Canberra Health Services, we've had 2 AHAs as part of our public health podiatry team. They were originally set up when the role of the AHA came into Canberra in 2012, 2013. One of those AHAs have recently retired, but we have been putting in a lot of strategies behind the scenes as to developing the internal education that would be required when they employ a replacement for the one AHA that they lost, because currently their AHAs sit at a level 3. They were independently running their own foot health clinics, and now their service delivery has slightly changed where they're coming into the inpatient setting a little bit more because we've got a slow stream service and they're working as the assistant for the podiatrist in that space. But I've been using multiple hats in order to do more investigations within that space, because we've also identified, and we're chasing up through many different streams, the lack of privately RTO accessible foot health education for the level to be able to upskill AHAs to be able to work within the podiatry space appropriately, because it's all well and good getting that training on the ground, but of course if they get that training after employment, that's going to take a lot of time off the podiatrist that they need to stay with the AHA before they get them to an appropriate level where they can leave them to be able to do tasks on their own. One of my challenges I've been doing at the moment, because when this staff member notified their retirement, I've been, yes, trying to problem solve as much as possible so that when we recruit another position for this role, for example, that there's already fundamental education on board so that we're educating the AHA to the level that they're required to be to continue with the service that's already being run without taking time away from the health professionals so they can still focus on the more complex patients.
Yeah, great. Yeah, I'd be interested to hear how that goes more in a private practice setting rather than public. But I've actually had 2 allied health assistants on placement in my clinic, and just struggled a little bit how to implement them clinically. Like they do really well with reception and sterilising and, you know, those sort of non-clinical tasks, but to get real value out of an allied health assistant, I'd really love to use them clinically somehow.
Yeah, it would be interesting to do a lot of risk analysis and determine what from your day-to-day duties, if you actually went through and did a bit of activity analysis and risk analysis, which of your duties you felt would be suitable to delegate and which of them you felt were too high risk from a clinical perspective for AHA to complete either under direct supervision or under indirect supervision. Because that's usually, I know how we work with our clinicians is, you know, for example, with a speech pathologist, certain things can be done, but certain things can't because of risk associated. With physio, certain things can and certain things can't because of risk associated. So it's sort of going through for each clinical activity, it's about that risk analysis and determining that worst case scenario, what is the worst case scenario in each of these instances? And is that within or is that external to the scope? Is that something that should be conducted with continual supervision? Is that something that can be conducted with distance supervision? Is that something that shouldn't actually be conducted by an allied health assistant, but actually needs to remain within the allied health professional scope because they need to be making a clinical judgment call on the day?
Yeah.
And
we haven't
that's
sort of sat through and done that yet.
Yeah, and for each of those tasks, if it becomes something where there needs to be a clinical judgment call on the day, that's going to actually determine your next course of action, that can't then wait for any feedback to then take it back to the allied health professional to go, this happened during this session. What do you want to do about it? Do you need to change the program? Do you need to do this? Do you need to do that? Then it's definitely not something that should be within the allied health assistant scope. It needs to remain within the allied health professional scope because they need to be able to respond immediately on the day in order to problem solve and follow through that next course of action. That's the way I would try to guide all of the different professions that we have.
Okay, great. Thanks, Amy. Thanks,
Sorry.
Thanks, Andy.
There's some more that have come through on the chat as well. The non-face-to-face duties of the AHA. Who is that from? From Linda? Need to have that in scope of practice. So AHAs are taking on more than just the face-to-face duties. They're actually looking at doing all of the other activities as well, creating resources and that kind of thing. Yep. Anybody want to make any comments about that?
Yeah.
Keely?
So I have had a very wide variety of experiences, very client facing or extremely involved in resource making, perhaps even a little bit beyond my scope. So I just think in terms of, because I love AHA and I'd love to see more people happy, satisfied, good job retention, some key points I would make is number one, being quite clear in your recruitment process. So I think that goes back to your operation level, so that when they come on board as an AHA, they know what is a realistic level to expect of the ratio to client facing versus administration task or whatever it may be. And I would say probably two more key points, but one other key point I would say is the more and more an AHA is involved in resource building or things like that, I would say sometimes you can tend to start to get outside of your scope, because you may start needing to make some clinical judgment, what's appropriate for this client, looking into equipment, things like that. That's when I would say you need to really err on the side of caution. And number three, I think, is just utilize, if an AHA does particularly really enjoy, they enjoy writing up like progress notes or reports or whatever it may be, that's absolutely fine to empower them to do so. But I think that it needs to be that they're developing a resource that's been very clearly delegated. So i.e., I would expect if I could get something from a speech therapist that says, this client is going to be doing this task, can you please find X, Y, Z? And it needs to be like a really, really small scale, if that makes sense. So it wouldn't be developing a speech therapy program. Yeah, I hope that does make sense to people in just terms of a functional level. I'm not saying to sort of dim the light of an enthusiastic AHA or to sort of not take on additional responsibility, because I do understand we do have a responsibility to support the allied health professional. I just think it needs to be very clearly delegated and quite tightly, yeah, really like quite a tight scope, if that makes sense. Yeah.
Kira, did you want to add anything? Yeah, go for it, mate.
Thank you. So I work with all NDIS clients, and because as part of our model, we have to have a program on file that the AHA is working from. So when we have that initial appointment with the client, the clinician and the AHA, there might not be a written program because the clinician is working out exactly what we'll be doing in that session. So then post that, because I'm taking all the notes or added notes, I can actually draft a program of exercises, particularly EP or physio, on behalf of the clinician, and then that draft is sent through to them. They will go through it, make any changes required, and then that program is approved by them and put on file. Now, the benefit of doing that is that if that clinician was to write up that program, the client's getting charged their rate. So for me to be able to put it together for them, we're reducing the cost to the client. The program's still exactly what the physio wants. They have to sign off on it, but the client is getting the benefit of a reduced price. And yeah, Ames, did you want to add to that?
Oh, and it's only based on what you've done in that joint session between you,
Absolutely.
the physio and the client. So it's basically
Yes.
just documenting what you've seen in that joint session, having them proof it and go, yeah, but you know what, I went away and I thought about it, and instead of doing 10 squats, I actually want them to do 3 sets of 5 instead of 2 sets of 5. So we're actually going to increase that. Now I'm going to sign off on it, and we add that to the file, and that's what's going ahead. So at times we can do that. One of the other things we do is, for example, speech programs. One of the things that can often be time consuming is printing out all of the documents, laminating it, cutting it up, putting the Velcro dots on the back so that it's then a communication book, or that it's a, so it's a low-tech AAC. So what we previously have done is that each of the AHAs would take it in turns to, depending on who was the busiest with their face-to-face versus who had a space available for what would be termed the resource development, they would actually carry for that period of time the AHA email. Now, the AHA email meant that literally any clinician that needed that level of, I need you to print out this, I need you to laminate it, I need it cut out, then I need the Velcro dots put on the back, or I need 20 copies of this done and I need it to this. They would actually have to send through the resource ready to go, and it's literally the last section. That the AHA isn't expected to find the actual clinical component. They are expected to do the printing, the laminating, the postage, the saving it to file, the, you know, those sorts of things. It's the equivalent of the cleaning the equipment, the returning stock, those sorts of things, to actually save the clinician time then at a later date, but also make sure the resource gets to where it needs to be. But not saying, oh, can you find me 20 examples of an activity that's going to get the client practicing the ooh sound? You know, that's not up to an AHA to do. So it is really, it comes back to that delegation again, but also as a company going, right, we're going to set aside this amount of time for those particular activities, and having that conversation and a negotiation with your AHAs to say, all right, whose turn is it? Who's got the capacity for this? Any other thoughts or comments?
No, I think the three of you summarised that very nicely.
We have a couple more minutes. Does anyone else have a question they would like to ask? Just while we're waiting for people to have a little think about that, Joe has just put into the chat box some links to our PHN weekly newsletter, so that you can come on our distribution list and receive that every week. A link to how we support allied health, and also a link to our education library. We have hundreds of webinars in there, and there are some on allied health, so please just type in allied health in the search bar and they will all come up for you. She's also put a link for our education calendar, which is fantastic as well. She's doing all the wonderful things for me and I don't have to worry. I've put in another link to the evaluation. We would love to get your feedback, so just click on it. It'll only take you 30 seconds to complete. It doesn't look like we have any more questions. No one's got their hand up. Yes, Keely.
Just one more thing for business owners from an AHA perspective, particularly when it comes to client funding, is trying to look at, before you actually employ an AHA, how best you can streamline the communication about a client. So that might be the really clear delegation report, and then exactly being very clear to the AHA how they're going to be documenting any feedback and providing any feedback. Because we don't want back and forth all the time. As passionate as we can be about our client, we want to still give them the right level of care, but keep it really streamlined. Otherwise, as much as AHAs are cheaper, you may end up chewing up funding just from too much communication. Yeah.
Great. Do any of our other presenters like to say anything else before we go?
Thank you very much. It was great.
Yeah, thanks for everyone for taking time to jump on and learn more about AHA. Lovely.
Yes, thanks everybody. And this, a copy of this webinar will be in our education calendar over the next 24 hours, along with the link to the video. So thanks everybody, and we'll see you next time. Bye.
Thank you.